Acromegaly.
Definition. Acromegaly is a disorder that results from excess growth hormone, GH, after the growth plates have closed. The initial symptom is typically enlargement of the hands and feet. There may also be an enlargement of the forehead, jaw, and nose. Other symptoms may include joint pain, thicker skin, deepening of the voice, headaches, and problems with vision. Incidence. Acromegaly affects about 6 per 1 lakh people. It is most commonly diagnosed in middle age. Males and females are affected with equal frequency. Signs and symptoms. Compared with the hand of an unaffected person, left, the hand of a person with acromegaly, right, is enlarged, with fingers that are widened, thickened and stubby, and with thicker soft tissue. Mandibular overgrowth leads to prognathism, maxillary widening, teeth spacing and malocclusion. Brow ridge and forehead protrusion remaining after tumor removal and tissue swelling eliminated. Lower jaw showing the classic spacing of teeth due to acromegaly. Features that may result from a high level of GH or expanding tumor include headaches often severe and prolonged. Soft tissue swelling visibly resulting in enlargement of the hands, feet, nose, lips and ears, and a general thickening of the skin. Soft tissue swelling of internal organs, notably the heart with attendant weakening of its muscularity, and the kidneys, also the vocal cords resulting in a characteristic thick, deep voice and slowing of speech. Generalized expansion of the skull at the fontanelle. Pronounced brow protrusion, often with ocular distension, frontal bossing. Pronounced lower jaw protrusion, prognathism, with attendant macroglossia, enlargement of the tongue, and teeth spacing. Hypertrichosis, hyperpigmentation and hyperhidrosis may occur in these people. Skin tags. Carpal tunnel syndrome. Causes. Pituitary adenoma. About 98% of cases of acromegaly are due to the overproduction of growth hormone by a benign tumor of the pituitary gland called an adenoma. These tumors produce excessive growth hormone and compress surrounding brain tissues as they grow larger. Other tumors. In a few people, acromegaly is caused not by pituitary tumors, but by tumors of the pancreas, lungs, and adrenal glands. These tumors also lead to an excess of GH, either because they produce GH themselves or, more frequently, because they produce GHRH, growth hormone releasing hormone, the hormone that stimulates the pituitary to make GH. Diagnosis. Frequent serum GH measurements in normal subjects, left panel, demonstrate that GH can fluctuate between undetectable levels most of the time interspersed with peaks of up to 30 μgl, 90 MIUL. In acromegaly, right panel, GH hypersecretion is continuous with no undetectable levels. If acromegaly is suspected, medical laboratory investigations followed by medical imaging if the lab tests are positive confirms or rules out the presence of this condition. IGF-1 provides the most sensitive lab test for the diagnosis of acromegaly, and a GH suppression test following an oral glucose load, which is a very specific lab test, will confirm the diagnosis following a positive screening test for IGF-1. Magnetic resonance image of a pituitary macroadenoma that caused acromegaly with compression of the optic chiasm. GH levels taken 2 hours after a 75 or 100 gram glucose tolerance test are helpful in the diagnosis. GH levels are suppressed below 1 μgl in normal people, and levels higher than this cutoff are confirmatory of acromegaly. Other pituitary hormones must be assessed to address the secretory effects of the tumor, as well as the mass effect of the tumor on the normal pituitary gland. They include thyroid-stimulating hormone, TSH, gonadotropic hormones, FSH, LH, adrenocorticotropic hormone, and prolactin. An MRI of the brain focusing on the sella turcica after gadolinium administration allows for clear delineation of the pituitary and the hypothalamus and the location of the tumor. A number of other overgrowth syndromes can result in similar problems. Mangament. The goals of treatment are to reduce GH production to normal levels, thereby reversing or ameliorating the signs and symptoms of acromegaly, to relieve the pressure that the growing pituitary tumor exerts on the surrounding brain areas, and to preserve normal pituitary function. Currently, treatment options include surgical removal of the tumor, drug therapy, and radiation therapy of the pituitary. Medications. Somatostatin analogues. The primary current medical treatment of acromegaly is to use somatostatin analogues octreotide, sundostatin, or lanreotide, somatulin. These somatostatin analogues are synthetic forms of a brain hormone, somatostatin, which stops GH production. Somatostatin analogues are also sometimes used to shrink large tumors before surgery. Dopamine agonists. For those who are unresponsive to somatostatin analogues, or for whom they are otherwise contraindicated, it is possible to treat using one of the dopamine agonists, bromocriptine or cabergoline. These drugs can also be used as an adjunct to somatostatin analog therapy. They are most effective in those whose pituitary tumors co-secrete prolactin. Bromocriptine lowers GH and IGF-1 levels and reduces tumor size in fewer than half of people with acromegaly. Growth hormone receptor antagonists. The latest development in the medical treatment of acromegaly is the use of growth hormone receptor antagonists. The only available member of this family is pegvisomant, Somvert. By blocking the action of the endogenous growth hormone molecules, this compound is able to control disease activity of acromegaly in virtually everyone with acromegaly. Surgery. Surgical removal of the pituitary tumor is usually effective in lowering growth hormone levels. Two surgical procedures are available for use. The first is endonasal transsphenoidal surgery, which involves the surgeon reaching the pituitary through an incision in the nasal cavity wall. The wall is reached by passing through the nostrils with microsurgical instruments. The second method is transsphenoidal surgery, during which an incision is made into the gum beneath the upper lip. Further incisions are made to cut through the septum to reach the nasal cavity, where the pituitary is located. Even when surgery is successful and hormone levels return to normal, people must be carefully monitored for years for possible recurrence. More commonly, hormone levels may improve, but not return completely to normal. These people may then require additional treatment, usually with medications. Radiation therapy. Radiation therapy has been used both as a primary treatment and combined with surgery or drugs. It is usually reserved for people who have tumor remaining after surgery. These people often also receive medication to lower GH levels. Radiation therapy is given in divided doses over 4 to 6 weeks. This treatment lowers GH levels by about 50% over 2 to 5 years. Radiation therapy causes a gradual loss of production of other pituitary hormones with time. Loss of vision and brain injury, which have been reported, are very rare complications of radiation treatments. Radiation therapy is generally used for people whose tumors are not completely removed by surgery, for people who are not good candidates for surgery because of other health problems, and for people who do not respond adequately to surgery and medication. Complications. Problems with bones and joints, including osteoarthritis, nerve compression syndrome due to bony overgrowth, and carpal tunnel syndrome. Hypertension. Diabetes mellitus. Cardiomyopathy, potentially leading to heart failure. Colorectal cancer. Sleep apnea. Thyroid nodules and thyroid cancer. Hypogonadism. Compression of the optic chiasm by the growth of pituitary adenoma leading to visual problems.
So guys, thanks for watching my video. You can like and comment on my video, but don't forget to subscribe my YouTube channel to watch quality content like this. Thank you guys.